Almost 30 years ago, when I was an intern in medicine at Massachusetts General Hospital, my mother called and asked me to come see my grandmother. My grandmother was 92 years old, had recently moved into an assisted living facility near my parents, and she had lung cancer. She was now short of breath, and she was clear she didn't want to go to the hospital. The pain and indignity of another emergency department visit was not going to change her outcome, and she knew it. My mother was panicked. She could not get any medical person to help her mother. When informed of the situation, my grandmother's doctor told my mother to call an ambulance and get her to the hospital. He refused to see her in the facility. My grandmother was awake and alert when I arrived. She had accumulated some fluid in her lungs, which is common with lung cancer, and I knew exactly what to do to make her comfortable. Sit her up, get her some oxygen, Lasix, and morphine. The facility director was upset that we would not call an ambulance. No one had yet died in his facility, and he had no knowledge of how to manage this. I called in the prescription, knowing that by prescribing narcotics for a family member, I was breaking the law. And I was angry that the facility was so poorly equipped to deal with this situation, and angry that I was putting my very new license to practice on the line to keep my grandmother comfortable. My grandmother lived for a week in my care, enough time for her children and grandchildren to say goodbye. That was my introduction to congregate living facilities in the United States. Fortunately, things have changed a lot since then, and they will continue to change. For this talk, I'm going to focus on 3 macro trends that COVID has accelerated: digital, hospital at home, and infection control. Let's start with digital. So pundits have been saying for decades that digital healthcare is coming, but you will surely have noticed that this has been remarkably slow. The first known telemedicine encounter using video equipment and computers occurred in 1968 in a link between my very own hospital, Mass General, and a clinic at Logan Airport. The slow adoption was initially about the clunky technology, but as your cell phones are proof, more recently, the barriers are not the tech. The objections have come from clinicians concerned about the quality of care, and payers' reluctance to pay for virtual consultations. COVID has very nearly destroyed both these barriers. Since COVID began, thousands of physicians and nurses have assessed and treated literally millions of patients throughout the country. The clear advantage of the convenience and obvious effectiveness has put concerns about quality in a much smaller box. And as you are likely aware, both government payers, Medicare and Medicaid, and commercial payers changed their rules and now pay for medical services delivered by phone and video. At Mass General, during more normal times, we deliver care at 55 sites to over 12,000 patients each day. Before COVID, we were delivering care virtually about 3% of all encounters. We are now delivering over 50% of care encounters virtually. That's over 6,000 visits every single day being delivered through technology. It is not perfect, and it does not come close to completely replacing the importance of and need for in-person encounters, but we are not going back. 2 other trends in healthcare we will see accelerate. First, the boundaries between types of care delivered in different settings are crumbling. Hospitals have for years been slowly transforming into large intensive care units, and at the same time, financial pressures have been pushing for lower level care to be delivered outside the hospital, such as residential and older adult homes. COVID is accelerating this trend as well, with minor acute illness and recovery moving to calmer and more comfortable home settings. Care is coming to patients instead of patients coming to care. I could have used that with my grandmother. Finally, the past 2 decades have seen mounting pressures on infection control in all congregate settings, including hospitals and all types of non-acute facilities. With COVID, the concentration of mortality among elders and the speed with which COVID can infect the populations of nursing homes, infection control has moved front and center for all congregate settings. We've long known that you can too easily get an infection in the hospital, and hospitals have had to respond by radically altering their workflows and procedures to minimize the risk. This is now the reality for all congregate settings. So what does this mean for you? First, shielding the elder population from infections is going to become a whole new industry. Infection control is going to be key. Adult children will demand the highest levels of infection control as much as they demand the amenities that will keep their parents comfortable. Right now, we're mostly doing the same infection control we were doing 30 or 40 years ago, primarily focused on disposable barriers and PPE, or personal protective equipment. Modern infection control is a combination of protocols and training, the built environment, and tech. We now have the capacity to turn normal rooms into negative pressure spaces, or even create a negative pressure space around a person's head using a clear plastic envelope and what amounts to a vacuum cleaner. We can restrict entry without hand sanitation. We can use UV light to eradicate organisms, use smartphone alerts for proximity monitoring and contact tracing, and communicate more easily using smart speakers and video. At first, the ramp up in infection control practices will slow everything down. But just like the TSA lines after 9/11, over time, the procedures and tech will evolve to become more efficient. Being at the leading edge of infection control safety will be a differentiator for your facilities. And in some states, this will be driven as much by regulation as by the market, because it's when the elderly get sick that healthcare delivery system gets overwhelmed. And then the dividing line between hospital and home is increasingly blurred. Hospitals are just not safe places for older adults, and we need to keep our parents out of them as much as possible. Being hospitalized is very uncomfortable, physically and emotionally, for our older adults. The overhead is incredibly high, and now so many things can be done safely and effectively at home, wherever home is. So we need to ask, do you really need to be in the hospital? The hospital at home concept has been used in other countries for decades, but regulations and entrenched interests have prevented it from taking off in the US. Those days are over. We can safely deliver IV medications, treatments for obstructive pulmonary disease exacerbations, monitor transient ischemic events using well-coordinated efforts between trained staff in living centers and healthcare providers. People with mild delirium or confusion can be treated in place. Conservative estimates suggest 20% of all hospitalizations can be safely and effectively managed outside the hospital. Here too, tech plays a major role. Now there's technology that allows for continuous monitoring, like a Band-Aid that Bluetooths to your phone, capturing all your vitals for 7 days and can be monitored from a distance. Across the country, paramedics are increasingly being used for emergency responses, and instead of transporting to the hospital, they are in real time consultation with physicians, doing blood work, obtaining portable chest x-rays, assessing patients, and starting treatments on site. Congregate settings are comfortable with this. They will have a real sales advantage. I have already described ways in which digital will support both infection control and hospital at home, but digital will also bring healthcare professionals into your facilities and into your residents' rooms. This is already happening, of course, but instead of it being the exception, the vast majority of encounters will be virtual. No more parade of lift vans in front of your facility. In order to make this work, local staff will need to participate with your elder residents, ensuring connections, facilitating computer-based assessments of heart and lungs, and ensuring changes in orders and care instructions are acted on. Every facility should be planning to build virtual consultation rooms. equipped with all the resources necessary to provide a complete examination, basic diagnostic testing, and even guide facility nurses through treatment plans. Why does the patient need to go to the emergency department when a full evaluation and treatment plan can be put in place right in your facility? Why would an adult child put their parent in a facility that was not equipped like this? Will these trends accelerate post-COVID? Certainly. All of these predictions depend on removing the main obstacles to change, the fee-for-service payment system. Changes in the delivery of services require a payment model that will support them. Two aspects of the current payment models are changing. First, the digital encounter is now reimbursed, as I mentioned earlier. This is a huge and sweeping change, and there are several elements related to the how much will be paid that remain contentious. But as I said before, we are not going back. With digital encounters paid for, they will proliferate rapidly. There is a second wave of changes coming as well. Subscription fees for a set of wellness and preventive healthcare services. In the 90s, this was known as capitation. But healthcare providers have learned a lot since then about the do's and don'ts, and numerous commercial insurers are experimenting with it, especially for primary care services. What does this look like? For a payment method, a provider organization will provide 24/7 urgent access remotely to consultation services, manage chronic illness and medications, arrange for specialty services, again remotely, and ensure care coordination with hospital-based services. Facilities will compete with each other for offering the best packages to seniors and their adult children. Those residents will want to access brand name hospitals and physicians at discount prices. Being able to show low rates of hospital admissions and access to trusted care when necessary will now be a selling point. Facility management will need to negotiate those deals. Unlike my grandmother, last year my father had a peaceful death in a memory care unit. The facility nurse coordinated care with family and hospice providers. We used voice-activated speakers, Zoom, and remote monitoring devices. And when he fell out of bed and had hip pain, his position in the bed told me from the nurse holding a cell phone that he had fractured his hip. And we were able to keep him comfortable in his bed until we could get an appointment as an outpatient to have his hip pinned. He didn't spend a single night in the hospital. So I'll leave you with these three take-home points to consider. Digital, infection control, and hospital coming to the homes you operate.